Welcome to our surgical grand rounds. This morning, I'm going to introduce to you someone who perhaps needs no introduction. However, I'll try to make it brief. Dr. Caprini is a senior attending emeritus staff surgeon at North Shore University Health System in Evanston, Illinois. Senior clinical educator at the University of Chicago School of Medicine. He recently retired as a clinical professor of surgery from that institution. He earned his Bachelor of Science degree in biology from Villanova and his medical degree from Hahnemann Medical College in Philadelphia. He has a Master's of Surgery from Northwestern University. He completed his general surgery training at Northwestern University and went on to completing his fellowship at the same school. Dr. Caprini is the author of the Caprini DVT Risk Assessment Protocol, a VTE risk scoring algorithm which has been validated in over 20,000 patients. He's a leader in the field of hemostasis and thrombosis who has authored more than 385 articles, book chapters, and abstracts. His participation on both the national and international stage has served to advance our understanding of the pathophysiology and management of this deadly disease process. Dr. Caprini's contribution to scholarship in the field has been significantly extensive and ongoing. Ladies and gentlemen, it is with great pleasure that I introduce you to someone who is an absolute trailblazer in this area, Dr. Joseph A. Caprini.
Good morning, ladies and gentlemen. It's indeed a great pleasure to be here, and I've already met many of you, and we had a wonderful dinner last night, and I just feel very excited to be here and to be in the presence of all of you enthusiastic people in terms of trying to learn more, and I was trying to keep my ears open, especially with the young people, to try to learn something from them because they're our future. Here are my disclosures. I don't do any, this is all advisory boards and educational activities. I don't give any promotional lectures. Venous thromboembolism is a terrible public health concern, and we don't know. There's various figures. One of those figures is that 900,000 people per year die of, could be affected, which is 1 to 2 per thousand, but that 60 to 100,000 Americans at least die of DVT-PE. John Haidt had the figure 3 times as high when he took a look at the Olmsted County experience. 10 to 30% of the people who get a clot will die within a month of the diagnosis, and sudden death is the first symptom in about 25% of the patients who have a PE, so that we have to be proactive. Among those people that have a DVT, 1/2 will have long-term complications such as the post-thrombotic syndrome and such as swelling, pain, discoloration, and scaling in the affected limb. Now, it's really interesting. 1/3 of the people with the DVT-PE will have a recurrence within 10 years, and approximately 5 to 8% of the U.S. population has one of several genetic risk factors that increases the risk for thrombosis. Now, it's very interesting that there's a certain group of us in the surgical specialties who consider the be-all and end-all clinical, presentable, fatal pulmonary emboli, and the rest of the problems associated with thrombosis don't seem to matter. DVT, clinical DVT, clinical pulmonary embolism, chronic pulmonary hypertension from pulmonary embolism, a hole in the heart, a septal defect, 25% of people have it, and 50% of the cryptogenic or unknown strokes are due to a DVT, where the clot goes from the leg through the hole in the heart to the brain. And all of these problems can be experienced in addition to clinical fatal pulmonary emboli, and they're critically important. They're life-changing in many cases. And this schema is just to show some of these things that. reason is because clots don't exist in a vacuum. It's associated with an inflammatory response. And in some people, they develop venous hypertension because the clots don't clear. And as a result of that, the venous valves can be disrupted. Post-thrombotic syndrome can occur. And the development of fibrotic occlusions and stenosis occur. And vascular remodeling and pulmonary hypertension and chronic hypertension can interfere with the normal activities. And I want to stop the music here 1 second, because one of the things in chest that infuriates many of us right now is that the new byline in the treatment guidelines say we no longer recommend compression stockings. These are not TED hose. They're 30 to 40 compression stockings for the prevention of the post-thrombotic syndrome. So now when you talk to the average internist, when I send patients, say, oh, stockings are out. And the patient's sitting there with a big swollen, tender leg. And the moment you put the stockings on, the pain and tenderness gets better, and the swelling gets better. And oh, by the way, read the byline in chest, which nobody reads. We acknowledge that a trial of compression therapy for patients with clinical symptoms, including pain and swelling, may be warranted. Time in. The Caprini risk scoring system is got my name on it, but I'm almost embarrassed about that because there's a litany of people, from nurses to PhDs to foreign medical graduates to internists to another surgeon, all kinds of people, my fellows. Without it, it wouldn't be here. But nevertheless, here it is. And what it does is assigns a point value to a risk factor and then totals the point to obtain a score. And you compare the score to the 30-day real VTE events, no screening, all real events, and obtain VTE rate for each score. And then you balance, every patient has to be balanced for the risk of thrombosis, for the risk of bleeding. And I want to announce right here and now, never forget, the most preventable cause of death after a surgical operation that a surgeon can influence, not beyond the surgeon's control now, like an infection or a heart attack, but the surgeon can influence, is a fatal pulmonary embolism. So what's the standard of care for every surgeon in America? To do their best to prevent the most preventable cause of death in their patient after surgery. And we'll get to that. Don't forget, there are minor surgical procedures, but they still may be major from a thrombosis standpoint due to the anesthetics. Anyway, these results have been validated now, and actually now we just passed 250,000 patients, and we were up to almost 80 studies worldwide. Here's what the form looks like, and it scores people for various risks. If you take a look at age, for example, or the number of risk factors, as the number of risk factors go up, the incidence of thrombosis go up. And as you can see from this list, from Worcester, Mass., from Fred Anderson and Brownie Wheeler, that different risk factors have different levels of causing a thrombosis. So you can't just look at the risk factors by themselves. You've got to look at their weights. And that's absolutely critical. And you know, young people don't have much of a chance of getting a clot, but I better finish this lecture fast because I'm at the wrong end of that scale. And that's without other diseases. I'd like to acknowledge Maxwell Borough, Somerville, New Jersey Community Hospital Chief of Surgery, who did some he was rabid about DVT, and he did some studies using fibrinogen scans confirmed with venography. And he showed that as the length of surgery, if you have an operation over an hour, 20% had a positive venogram. And that was because of the effects of anesthesia. It didn't make any difference if it was a small or a big procedure. And as the time of surgery went on, the risk went up. AIDS, the same thing. We just saw AIDS from Andrew Nicolaides. Now we're seeing it from Maxwell Borough. This is where the Caprini score started, and it probably took me 15 years to figure out, because I worked with Maxwell, that actually we had used that in our calculations. So the basic assumptions are the more factors the patient has, the greater their likelihood of developing a VTE. The strength of each risk factor is important. In those days, abdominal operations that last over an hour, 20% incidence of VTE venographically. If the operation was for malignant disease, it went up to 36%. And Borough's bombshell was that in patients with a prior history of venous thrombosis who had an operation, 66% of them could be expected to get a recurrence without prophylaxis. Note, 20 for benign disease, 36 for cancer, 66 for a history of thrombosis. It's the single most important factor, along with family history, that's going to take a simple arthroscopy, a simple Achilles repair, and turn it into a nightmare and a fatality. And you'll see 8 of them at the end of this lecture, collected in the last year. Individual risk factors are each associated with a given risk. However, when the factors are weighted and considered together, the result is much greater. If we take 3 or 4 of us and put us together, we will have a synergistic effect that no one person can match, because we're working together. What happens here is that's what's happening with this. It took me about 20 years to figure out that we had a synergistic effect, and that's why it worked, because I was amazed that it worked, but that's why it worked. You can't use chart review. It's flawed, because people haven't, you don't know that people have asked the questions. So we've come up with a system where the form is completed by the patient. When you go to the dentist, you have to fill out your health history. What about when you go for an operation that could result in a death if you don't have the right factors? And then the healthcare professional, we found, can check that form in 5 minutes and calculate the score. And the score revised during the hospital stay. If somebody perforates their bowel or somebody has to go back to the operating room, then they have infection, they get antibiotics, they get a central line, they get another operative procedure. You got to add all that up, because that'll influence the eventual outcome. And cancer diagnosis, you come in for a benign diagnosis, it turns into cancer. Time out. Number 2. The medical community, the most brilliant people in the world, hematologists, pulmonologists, family practice, all those medical people. You know, they say about the surgeons, we don't know much, but we do it all. And the medical people don't do very much, but they know it all. And the pathologists do it all and know it all, but it's too late. Anyway, the Padua score, the improved score, the 2 scores that are recommended for risk assessment in the medical population, they both don't have family history of thrombosis in the form. So every time there's a history of family history of thrombosis, that patient has not been scored properly. And in the ISTH on World Thrombosis Day in October is going to come out with recommending the Padua improved score for medical patients and the Caprini score for surgical patients, non-orthopedic, throughout the United States. Anyway, time in. Now, this is a study done by Christopher Panucci, who's one of the most brilliant young investigators, and he conducted a chart review at the University of, it was from the University of Michigan and then went to the University of Utah on the staff as an attending plastic surgeon. And he showed that chart review, and there's a whole litany of all the factors, I'm just showing 2. I'll never forget this. I was in the audience one day and they were doing a total hip procedure, and I said, did the patient have any obstetrical misadventures? And the chief turned around and snapped at me. It's like, oh, he's here again. We're fixing this lady's hip. We're not interested in her having, she's not having babies. No, but what you don't understand, if she's had a history of an unexplained stillborn infant, recurrent spontaneous abortions, premature birth with toxemia, or growth retarded infant, she could be carrying the antiphospholipid antibody syndrome, which is an incredibly powerful stimulant for producing a clot. It's a major acquired thrombophilic factor. If you don't ask that question, you won't pick those people out. It's a simple test. You can do it very quickly. But that would change the risk level, and maybe now in modern orthopedic surgery, where aspirin is now commonly used, and many of these lower risk situations after total joint, maybe that would influence you to not use the aspirin in that patient, but maybe go to one of the newer anticoagulants or whatever. Anyway, that's a story about that. How about family history of thrombosis? 5.2% in the record, 17% with the live face-to-face. There's no substitute for the face-to-face. I know it might be too time-consuming, but you have to patient fill it out. And the other thing is that also gets me angry is when they ask nurses, operating room nurses, same-day surgery nurses, admitting nurses. They're not supposed to be doing the history and physical. They're supposed to be checking over things, making sure they're done, making sure the history was done, making sure that it's the right limb, and so on and so forth. Let the patient take responsibility for this and have the responsible PA, resident attending, then just check the form. Here's the form. This has now been published in Thrombosis and Hemostasis, and these are the risk factors. I certainly want everybody in the audience to have everything I have, and I also recommend all comments, especially the critical ones, because that's how we learn. I'm not up here to hear myself talk. I'm up here to help you save your patients, and if I have flaws or the things I can do it better, I want to hear them. So here's the form. It works out very nicely, and the patients were able to fill the whole form out except for BMI when it was compared to. This study was done having professionals interview the patient, and then the patient do it themselves, and it was blinded and put together. And not only does it work here for English, but we now have under review, it hasn't been accepted yet, but it's under review, Spanish, Arabian, Chinese, Polish. I think that's it. The same thing we did with that, so that we, all by people of those nationalities too. Again, there's no question that a thorough history and physical isn't important. And if you have surgery, wouldn't you want your surgeon to say that I am poring over everything that could possibly jeopardize the outcome of the procedure, or change my approach to the procedure, or change my informed consent to the procedure, or maybe talk you out of the procedure if it's a quality of life improvement procedure? Or would you want them saying, well, we just looked over the high points, everything is okay, let's go. I know my business, stand back some, we got this under control. This is a series of 4 studies, the first 4 studies, and every study that's been done so far where the questions have been asked properly, there's the answer. As the score goes up, the incidence, the clinical, the 30-day real clinical incidence goes up, except for the red ones on the upper right. That's 60 days. Plastic surgery procedures, nobody got prophylaxis. If their score was over 8, 11% had a clot at 60 days. Clinical clot, and a lot of them occurred late. Why, I have no idea. I would think that the highest risk patients, they'd occur right away, but that's not what happened. So anyway, there you are. The Caprini scoring system was really successfully implemented. Well, since October of 2009, it's mandatory at the University of Michigan for all patients except psych patients and terminally ill patients and pediatrics. In Boston University put this, what I call a success story together, combining a mandatory protocol. It's no good to have people fill out the form. Make them fill out the form. They've got to follow a care pathway that's tied to clinical data. And as I'll show you, if you think that you can give 1 or 2 doses of anticoagulant and prevent a venous thrombosis, think again. I'm going to show you studies in 1 million patients where that was found not to be true. You got to give it for the period of time the patient's at risk. According to clinical trials, it's 7 to 10 days. What do you do for antibiotics? You do it according to the clinical trial data. So Boston had this mandatory system where you had to do the score, and then you had to sign the orders, and the prophylaxis was mandatory unless you could always opt out. Oh my God, you always want to give the surgeon the chance to do what they feel is individually correct, and all they have to do is say, you know what, I don't agree with this. I'm not going to do it. Fine. That's not my problem. We never want to take away free will. But for the most part, and we found in Michigan that 99% of the surgeons eventually just went along with the program because it seemed to work. And as you can see, the first 3 categories, 0, 1 to 2, and 3 to 4, there was 100% compliance, and this was during hospitalization. You'll notice that heparin and low molecular weight heparin are in because this study was done when the SCIP protocol was mandated. The Joint Commission mandated that patients get a dose of anticoagulation within 24 hours of their surgery unless they were high risk for bleeding. So they had to include that here. If we were rewriting that now, we wouldn't put it in there because you don't need prophylaxis for those lower scores. And if they had a score between 5 and 8, so they were really the risk group, they got 7 days of low molecular weight heparin. And if they had a score of 9 and above, they got 30 days, and you can see the compliance, 89 and 77. Now, this wasn't some fancy Boston hospital in the rich neighborhood. This was the indigent hospital, Boston University, 503 beds. And God bless the administrators. They worked to deal with the company and through the pharmacies so that every single patient that needed the drug got it, regardless of their ability to pay for it. And it's a model for the nation, and here's their results. They started out very high. This is the average in NISQIP, and here's what they got down to, 0.1%, 0.2%. And when they threw in the orthopedic population, it came back up a little bit, but it was still very low. Time out again, number 3. NISQIP, the National Surgical Quality Improvement Project. Wonderful project. dedicated nurse keeps track of 23 complications for 30 days in a selected set of surgical patients. Selected set of surgical patients. It's closing in on 5 million patients in the database. They've come up with some great care protocols and some great things, especially infection and everything. I met your local NISQIP person. Fantastic program. Bravo, bravo. Wait a minute. They don't track if the patient's had a history of thrombosis, past history of thrombosis, a family history of thrombosis. They don't track use of prophylaxis, type of prophylaxis, length of prophylaxis, dose of anticoagulant. Hello? For VTE, any NISQIP study you look at is flawed because they haven't looked at the data that you need to look at to pick that bad apple out of the barrel. You can sit there, for example, you can sit there and say, all right, I do orthopedic surgery and I just saw this article that 20,000 lower extremity injuries were repaired and the incidence of DVT was like 0.2%. Come on, we don't have a problem. Okay, let's do a little experiment. Let's look at hair covering in the audience. And we're going to average everybody together, and we're going to come up with an average hair cover. Where do you think I'll fall? I'm an outlier. I'm the bad apple in the barrel. I'll be in that 0.2%. That's what I mean. That's the people that need to be plucked out of there and protected. And you'll see my list at the end. There's just a few I've collected in the last year where weren't protected, and they died. All right, time in. Now, this is another study. There's almost 80 studies, but Christopher Panucci, brilliant young man, went through them all and combed them all and came up with the 13 best studies. These were the primo studies in the meta-analysis. And the most important thing he showed is that if people, depending on the person's score, if they didn't get prophylaxis, those patients had a 10% incidence of venous thrombosis if the score was over 8. If it was 3 to 4, it was 7/10. Now, he said that Caprini scores of 6 or less were 75% of the patients, and there's no significant reduction in VTE using prophylaxis, suggests mechanical prophylaxis except for hematologic risk factors, minimizes bleeding risk in these patients. For Caprini scores of 7 to 8 and scores of greater to 8, statistically significant VTE reduction postoperatively using anticoagulants. Now stop the music. Fabulous study. We were all excited. The meta-analysis shows that Caprini score holds up. But now what do? Does that mean that anybody that has a score of less than 6 doesn't get anticoagulants? What about the other 70 studies around the world where people in various countries and in our country, including Boston University is not one of the premier studies here because it didn't meet the criteria. So we're going to throw all that data out because it's not evidence-based. The meta-analysis is the total evidence-based answer. Well, there isn't a surgeon in this audience, I can promise you, that ever operates and practices with evidence-based only. Sure, you start with evidence-based, but then you get into this practice of surgery, which is, it gives me chills sometimes thinking about the responsibilities we take on and what we find at operation. We have no idea they're there. We haven't seen them before. Maybe we haven't even been taught that. We've got to make it up as we go along. That's not data-driven. It's known as experience. Brunswick did pelvic exonerations, and one day at Memorial, he put a patient on the table at 8 a.m. By 12, she bled to death. Put another patient on at 1. By 5 p.m., he bled to death. Brunswick wrote the book on this. He had the data. He started to revamp it completely, going against the previous data. Why? Because the clinical result was undesirable. So that I take exception with people that say, I'm not going to do this because it's data-driven. And at the bottom is one of the things that I think is the most serious, and to me, it makes going around talking about this really worthwhile. Caprini score is fine, but it's just a guide. If you have inflammatory bowel disease, then stool is getting into the bloodstream, triggering clotting all the time. That's a hematologic risk factor. I don't care what your score is. If you have surgery, you need protection. If you have a family history of thrombosis, you need protection, because otherwise, you know what? You could die. Because those things are passed on genetically. Sometimes we can't even measure what's passed on. And you'll see more about that later. So it's really, really important. Yes, this is fine, but it's not the be-all and end-all. And of course, we have to take a look at complications. This is a study, 33,000 clinical trials and 33,000 patients. And the giving of anticoagulants is not without its risks. There's no question about it. Now, unfortunately, not all of us understand the data, which we're now going to get into. Postoperative bleeding to cause a death is a rare, very rare event. But withholding anticoagulant prophylaxis in a surgical patient is associated with an increased incidence of fatal VTE. And you know what's sad about this? And especially I have to go to orthopedics because the orthopedics, including me, they're incredibly skilled. And those skills have become more and more refined over the years. And their incidence of all kinds of complications has been reduced to a very minimum. And those doctors that do large volumes of these joint replacements, for example, man, they've got this thing down. And it's really working well. But you know what happens when a patient comes in and you've operated on that patient and they come back with a big hemarthrosis? That knee may never be the same. Scotty, I was on the ski patrol at Big Sky during the winter when I stopped doing surgery, and Scotty was a snow safety man. He went up on the mountain to the very peak in the beginning and sussed the avalanche risk and came down the most treacherous of all runs to test them. And one day he fell on that run, and he ruptured his ACL. And he had surgery. And Scotty developed a postoperative hemarthrosis, and Scotty never was able to get back to skiing. And of course, the orthopedic surgeons that did that, we all feel personally responsible, so we have to see those things. So I just want you to understand that I'm a surgeon, and I've been a surgeon for 41 years, and I understand the fright and how personal these things are when you don't get a good result, and especially if, by God, you were going to give some anticoagulants to a bleeding patient, to a surgical patient. But it's about saving deaths. And here is the start. This is the genius, VJ Kakar. And people would say, well, you know what? Why should I listen to general surgeons about using prophylaxis? Well, here's where it all started. VJ was a general surgeon, and he organized a clinical trial in 1975, 4,100 patients. Primary endpoint was fatal PE. They were either given unfractionated heparin 2 hours before surgery and every 8 hours postoperatively for 7 days. 180 patients died during the postoperative period, 100 in the control group, 80 in the unfractionated heparin group. Rate of autopsy, 70%. Fatal pulmonary emboli in the control group, 16 in the heparin group, 2. It's 4,000 patients. They thought he was a fraud. He's pulling a fast one. He's from India. He's not. We don't believe him. Ulrich Gruber was very publicly attacking him for his results with the trial. Along comes Rory Collins, an Oxford scholar, 15 years later. Rory Collins went back and looked at the Kakar design, and he looked at 70 additional trials in 13,000 more patients that followed the Kakar protocol. Guess what? The results were the same. Kakar wasn't a fraud. It was a well-done trial, but you know, in 1975, I was there. I knew VJ, and I was there, and I listened to the trial, and I came back to the hospital, and now I'm running a clotting lab. I'm doing surgery. The chief really is enthusiastic about me. He sent me for a coagulation fellowship, and I said, I'm going to start giving heparin to the surgical patients. He said, Joe, are you out of your mind? Patients a drug we don't understand except we know it causes bleeding, and then you're going to operate on the patients? You know, try something else. And so I got into pneumatic compression devices, and that's how that went. But that was the culture at the time. But look at this. And so here now we have 20,000 patients, 94 medical centers around the world over a 15-year period, and the incidence of fatal pulmonary emboli in the control group is 55 compared to 19, 9/10, 3/10, 66% risk reduction using the heparin. What about bleeding? There's no difference. Fatal bleeds, 7 in one group, 6 in the other group. So there wasn't an increase in bleeding, but there was a 66% risk reduction in fatal pulmonary embolus. Now, apples don't fall far from the tree. Along with Sylvia Haas, a famous internist from Munich, and A.J. Kakar, VJ's son, they published a trial in 2005 with 23,000 patients given prophylaxis for 5 to 20 days. Notice the length of prophylaxis. We had 7 days in 20,000 patients. Now we have another 5 to 20 days in 67 centers and 23,000 more patients. Where did you get giving it for a day? Where did that come from? Fatal pulmonary embolism was the endpoint. 0.1%. So I tell all of my high-risk patients, if they're going to have surgery, and I've seen lots and lots and lots, especially orthopedic patients, and I'll say, you know what, you're at very high risk for thrombosis, and without the proper prophylaxis, there's a 5% chance you could die. But if we give you heparin or low molecular weight heparin for at least a week, we know the statistics are a tenth of a percent fatality. So I think that's a pretty good algorithm. And oh, by the way, although there weren't joints in this, there were 21% of these patients were orthopedic. So anticoagulant prophylaxis reduces the risk of death to a tenth of a percent. No deaths from anticoagulant bleeding, excessive postoperative blood loss, 2/10 of the unfractionated heparin and 1.3 of the low molecular weight heparin. This was a study that was sponsored because they were trying to prove that low molecular weight heparin was better than unfractionated. While it may be, the death rate was the same. So we have from 1975 to 2005, 43,000 patients, 160 centers, objective diagnostic endpoints, venographically endpoints, or autopsy adjudicated PE, anticoagulant prophylaxis for 1 week, established efficacy. If you don't know the literature, then you're going to have to repeat it. And until you get it, people will die. Sorry, I'm having trouble making up my mind. For Chest Consensus Conference 2008, for patients undergoing major general surgical procedures, we recommend that thromboprophylaxis continue until discharge from the hospital. What? Did you not see all of that data I just showed you? What happened to all of that? How did that? And one of the reasons is that these guideline documents are a lot by consensus. I was a ski patroller for 8 years, and on a beautiful March morning, I come off the peak at 11,000 feet into a couloir, and with a 19-year-old brain and a 71-year-old body, I crash in the rocks, self-arrest, saving a 3,000-foot fall down the mountain. I had to be taken out by ambulance. I had a compartment syndrome, a big tibial plateau fracture. Marvelous surgeon. Put in a plate, the Philadelphia plate with the 13 screws, fabulous. I was in a wheelchair for 3 months, and following that, I anticoagulated myself for the whole time. But surgeon comes around and he says, we're taking the drain out and everything looks good. And I said, fine, start the Lovenox, start the Coumadin, and by the way, I want to get scanned before I go home. And so anyway, the thing is that so I would still send that every time I see that orthopedic surgeon. It was marvelous. He saved my life. But I had a previous history of a clot from another skiing injury in the past, and I was old, and I was overweight. I wasn't too overweight actually, but. You know, that was enough. And I averted a clot, I think, because of being the bad apple in the barrel. But nobody ever asked me if I had a clot. Nobody ever asked me if I had a family history of thrombosis. I didn't have the family history of thrombosis. So now, most hospitalizations are 1 to 3 days in 2017. Can the CHEST guidelines suggesting prophylaxis until discharge be followed in 2017? I strongly recommend that you don't do that. And if you don't believe the data, then, you know, that's your business. But you're not going to send my daughter, my wife, my friend out without a prophylaxis that I know is based on the literature, that I know what needs to do that to work. So, a meta-analysis of 51 randomized controlled trials CHEST did in addition to what I've already told you, and this was in 2012, and showed that in general and abdominal surgery patients, most studies follow up was 7 days or 1 month. And the risk was 30% lower in low molecular weight heparin. But the authors did not emphasize providing prophylaxis for 1 week, despite the fact that this period was shown to be efficacious in the 51 trials used to provide the above conclusion 2.5. Time out. I had the dubious distinction to be the co-chairman of the Joint Commission's panel on venous thromboembolism with Dale Bratzler, a famous epidemiologist from Oklahoma. And when they introduced this business about the skip, they said, you know what, why don't we put a statement in there that we're getting people to start using prophylaxis after. We want people to start using the prophylaxis, but we do not intend by any fashion that one day is enough because of all the trial data, and it was vetoed. Said, well, you know, it's a level above us. CMS does what CMS will do, so anyway. Now, the Boston success story further emphasizes the 7 days. So they had to reinvent that, didn't they? Kakar showed that in 75. Boro showed it in 81. Collins showed it in 1988. In 2012, 51 more trials showed it. And now, along came Boston University. They had to reprove all of that. Nothing like human nature. So let's take a look at this SKIP project. 30,000 patients in the VA were linked to it. 89% got the shot, 1.4 incidents of DVT. 11% didn't take the shot, 1.3 incidents of DVT. Authors concluded there was no association between SKIP VTE adherence and the incidence of postoperative VTE. That was 30,000 patients. How about 500,000 more? John Haidt, the most famous epidemiologist of all time, I think he's kept track of every person who ever lived in Olmsted County. Fabulous investigator, brilliant man. He was on our Joint Commission, of course. And what he concluded was that the VTE events, he just published this in 2017, the VTE events from 2005 to 2010 are unchanged, except the one difference now is there's near universal in-hospital VTE prophylaxis, possibly due to short prophylaxis duration. The mean duration of prophylaxis was 70 hours. A short course of anticoagulants is ineffective in lowering the VTE rate. Identify high-risk patients that would benefit from extended prophylaxis. So we're up to 530,000, correct? All right. Now we talk about orthopedics, and the same thing comes from the Journal of Arthroplasty, where they show that and the title is Surgical Care Improvement Project. Has its mission succeeded? It failed. The incidence of thrombosis has gone up, despite the fact that everybody was doing it. Okay. Now let's throw in another 779,000 patients. SKIP adherence improved by 14.6% during the study period over 5 years, and 6.4 and 20%. Postoperative DVT rate increased. PE rate increased. I rest my case, Your Honor. No further questions. It's over about 1,300,000 patients. 4 different studies all over the world. Now, my brilliant fellow, Dr. Juan Arcelis, who was partially responsible for putting the Caprini score where it belongs, because he really took it. I was sort of wallowing around with it, and he said, oh, well, let's take a look. So they did 1,000 medical and 1,000 surgical patients, and then he really got it going. But he published this study when he was with us, and it showed from the RIETE database, which is the largest clinical DVT database in the world, 132 countries, that 77% of medical and surgical patients, when they left the hospital, is when they got their clot. And 53% of them, or 55% of them, were diagnosed after the prophylaxis was discontinued. So, this intensifies my approach of making sure that you look at the data and that you give prophylaxis for the period of time known to affect VTE prophylaxis. Here's a series out of the NISQIP database, 650,000 patients. Oh my God, wouldn't it have been nice to have the right DVT data in 650,000 patients? What a mind source. And I've talked to Coe about this, Dr. Coe, and they promised they were going to do something, but they haven't done it yet. And the total PEs, and as you can see, they don't all occur right away. They occur over the first 30 days. So, CHEST guidelines consider history of thromboembolism in the highest risk group of patients, along with cancer and total joint replacement, and indicate that the risk of thrombosis is 40 to 80% with a 1 to 5% chance of a fatality. Now, those numbers go back to 2004 and were repeated in 2008. That was based on venographic data, and of course, a lot of things have changed since then. But the point is that a history of VTE hasn't changed. An operation, a hip hasn't changed, cancer hasn't changed, and I already showed you from the 80s what the difference is in cancer. Incidence in cancer patients was 36%, it was 66% if they had a past history of thrombosis. We're going to have to reinvent that, I think. For selected high-risk general surgery patients, including some have undergone major cancer surgery or previously had a VTE, we suggest a continuing thromboprophylaxis after hospital discharge with low molecular weight heparin for up to 28 days be considered. Chest 2008. They came back in 2012 and they left out the VTE, history of VTE. They just talked about cancer, and despite the fact that now they had much more robust data from 3 meta-analyses where the risk of symptomatic DVT was reduced 50% and 2 reported that proximal DVT was reduced by 75% in people that were in the highest risk group. Well, why didn't they mention what they said in 2008? Was that wrong? Was all that data wrong that they made their conclusion on? And if so, did they show us now why they didn't put that in? In my opinion, a personal and family history of VTE, total joint replacement, cancer, thrombophilia, inflammatory bowel disease, ongoing risk secondary to leg cast, immobilizing brace or boot, infection requiring IV antibiotics, all ought to be considered for thrombosis prophylaxis. Timeout number 4. We have always known that Buckingham Palace guards and the military should not stand with their knees straight, perfectly straight, at attention, because what happens many times, and the vascular surgeons know this, is the popliteal entrapment syndrome occurs, where when you extend your leg fully, and I have videos of this, it shuts down the popliteal vein, forcing the blood to go around. Now, if you have a patellar fracture, or if you have a quad rupture, and you have to be in an extended brace, that's a risk factor, because if you have the popliteal entrapment syndrome, you're setting yourself up for a clot. Over and above immobilization, over and above non-weight bearing. Interesting, isn't it? Now, the other thing that's crept into our society, which is ridiculous, is the nurse will come around and tell the patient, well, if you'll get out of bed today, I don't have to give you this shot. Well, what has that got to do with anything? Ambulation has no effect on existing risk factors, such as cancer, history of VTE, and only decreases the risk associated with mobility. So yes, you get up and out of bed, you're going to reduce that risk that you would have from being in bed, but it doesn't take away your history of family, history of thrombosis, your cancer, your inflammatory bowel disease, your anticardiolipin antibody from an obstetrical misadventures. Hello? There's no data. Recurrent thrombosis postoperatively. As I said, 66% who had a history of venous thrombosis suffered of venous thrombosis postoperatively. Here is a study, and it's on 183,515 individuals from over a 20-year period, that the incidence of, sorry about that, the incidence of DVT, I thought I had arrows here, I guess I don't. The incidence of DVT is an increased risk, not only among first-degree relatives, but also second- and third-degree relatives and non-biologic relatives. The genetic component of the family clustering of VTE is strong. Family history is potentially useful for clinical VTE risk assessment, even in second- and third-degree relatives. 2013, Thrombosis and Hemostasis, the #1 clotting journal in the world. Now, go to Up to Date and look this up. Ken Bauer has a beautiful discussion in there, says nothing about this 183,000 patient study. So young people, beware. And then, these days, you've got to go to places like Up to Date to see the latest stuff. What if it's not right? Interesting. Family history, this comes from 2009 from the Archives of Internal Medicine. Family history is a risk factor for the first venous thrombosis, regardless of the other risk factors identified. In clinical practice, family history may be more useful to risk assessment than doing thrombophilia testing. And the family history may reflect genetic risk factors. Carriers of a genetic risk factor are at increased risk of a first venous thrombosis, particularly when exposed to environmental triggers. Surgery, muscle ruptures, immobilization. I know you know how to read, but I'm trying to emphasize this. Plaster cast, extended bed rest, hospitalization, pregnancy, use of oral contraceptives, diagnosis of malignancy, 5 years before or 6 months after the index event. Patients with a positive family history, almost 30%, had a genetic risk factor. The chance of finding a genetic risk factor was up to 36% of patients with several affected relatives. The relative risk associated with a positive family history was of a similar magnitude as the risk associated with a genetic risk factor. So if you have a positive family history and you've never had a clot, it's like you're carrying a thrombophilia marker, and that's an extra risk for thrombosis. So a combination of genetic and acquired risk factors resulted in a 60-fold increase than for those with no known risk factors, and a positive family history increased the risk of venous thrombosis more than 2-fold, regardless of the risk factors precipitating the thrombosis. 2009, I didn't see that in up-to-date, and here's the list. And I would take you, I know we have some, here's a lady with large breasts, a career military, and she underwent a bilateral reduction mammoplasty. She had an elevated BMI, history and family history of PE, no prophylaxis, and she suffered a worse fate than a PE death. She got a PE and a spinal cord thrombosis, rendering her paraplegic. Patellar fracture, abdominal wall tumor, died. Motorcycle crash, hip dislocation, BMI, microfracture, no prophylaxis, in a brace, died 6 days later. Quad rupture, immobile, brace, surgery 1 month later, no prophylaxis, 7 days post-op. Cycle crash, BMI 34.7, immobile brace, 2 weeks ORIF, arrested on the table with no anticoagulation. ACL, injury repair, BMI, inflammatory bowel disease, cast, immobility, fatal PE 3 weeks post-op. And the one that rested on the table is when they put the Eschmark bandage around to exsanguinate the leg, the clot from the leg went up to the lungs, killed the patient right then and there. So all of these deaths preventable utilizing preoperative scanning and or appropriate length of thrombosis prophylaxis. The defense in one of these cases was, I said, well, the patient's been in a brace for a month. They've had no prophylaxis. They're immobile. Oh, it was 507 pounds. This is a real case. And you mean to tell me that you shouldn't have checked their leg before you put them to sleep? Before you put the Eschmark bandage on? No, we don't. CHEST doesn't recommend routine scanning after total joint replacement. Hello? This isn't routine scanning. This is not postoperative. This is not a total joint. This is preoperative scanning for cause, for suspected cause. So, in conclusion, risk assessment using the Caprini score, utilize the patient-friendly form and verification, avoid chart review, face-to-face is critical, provide prophylaxis for at least 1 week in the risk of score of over 5, extend prophylaxis for at least 28 days, cancer, joint replacement, and prior VT, and or score of over 8. So if the score is less than 8, loud and clear, I can't wait to get this on my website. You still need to use 30 days of prophylaxis because that's shown to statistically significantly lower the incidence of venous thrombosis compared to 7 days, and that can be with any of the drugs that are approved for any of the indications. And the hematologically based risk factors are the most dangerous: history of thrombosis, family history of thrombosis, inflammatory bowel disease, obstetrical misadventures, and the like. Ladies and gentlemen, continue prophylaxis for as long as the risk is ongoing, and pay very attention, if I haven't already beaten it to death, about personal and family history. With that, thank you very much. It's been a great pleasure. I'll try to answer questions.